around working hours and lighting exposure. And his work has influenced policy in the United States. And from our conversations over coffee, it sounds like British Columbia also needs to take notice of some of these policy recommendations to improve working conditions for our clinicians as well, which apparently aren't as good as we might have thought. So welcome. I look forward to your talk.
Thank you so much for having me. I'm thrilled to be here. So this is how the talk is organized. We're going to start with a focused discussion on fatigue, performance impairments, how sleep deficiency and circadian misalignment impacts well-being and safety in the workplace. And I'm going to focus for a little while on work hour limitations, specifically among resident physicians, as that's been a consistent focus of my own. And we'll talk about fatigue risk management approaches in a couple of different settings. And then at the end, I hope we have time to pivot to a couple of active projects that are ongoing that have great potential for collaboration with people here and that you may be interested in. So in terms of what makes someone feel fatigued, the first is obviously the number of hours that they're awake. Call that acute sleep deprivation. For every additional hour of wakefulness, you tend to perform a little bit less well. Nightly sleep duration or chronic sleep deficiency. So chronically curtailing and getting less sleep that you need over a prolonged period of time impacts your performance and your subjective fatigue. Third is biological time or circadian phase. Let's talk a little bit about circadian misalignment and how that impacts sleep and performance and how that interacts with sleep deficiency as well. Fourth being sleep inertia. That's that sensation of grogginess that you feel immediately upon awakening that also is a marker of impaired performance. And finally, sleep disorders. So the first is a study that's been cited thousands of times, and I'm sure you're familiar with this Dawson and Reed paper from 1997, where they brought in 40 volunteers. They participated in the lab under two conditions. First, or second, consuming alcohol until their BAC reached 0.10, and then on the other visit, 28 hours of sustained wakefulness. And they found that after about 20 hours of wake, their performance was similar to that of someone who had a BAC of 0.08. This study was largely replicated a few years later, and I think got much less attention, but it has a lot of operational application. So this was done at Brown, where they took 34 pediatric residents right from their work shifts under a couple different conditions. One being a light call, so they're working at 24 no more often than once every 2 weeks or so. The second being a standard schedule, which is called heavy call here, and that's when they're working 24 more hours every 4 to 5 days. And then after one of the late call shifts, they added alcohol to a BAC of 0.5. And after the heavy call shift, they came in twice. One of them, they also got placebo. And what they found was that there was actually no difference between a light call schedule with intoxication and a heavy call schedule without any alcohol in terms of their PVT performance. And it looks like they might have even done a little bit different, a little bit worse on a simulated driving test, which they did in that same visit after a heavy call schedule compared to someone who was at 0.05. And this is something that I think is commonly overlooked, even though there have been a series of studies that I'll briefly touch on later showing an increased risk of a crash coming home from a work shift that's 24 or more hours. It's not often that I think employers consider the legal ramifications of this, and it's increasingly a focus of states to try and identify drowsy driving and enact enhanced penalties for those who have been knowingly awake for a prolonged period of time. So employers who are asking people to work 24 or more hours, if they're in Arkansas, that driver going home if they haven't slept can be sentenced to a felony and have up to 20 years if they're involved in a fatal accident, just for following their work schedule as designed. New Jersey has a similar law where they enhance penalties if the person has been knowingly awake for a prolonged time and they cause an injury to someone else. So a huge legal liability here. In addition, this is a classic study by Hans van Dagen. I just want to highlight the difference in acute and chronic sleep deficiency that you see here. This experiment, after 10 days of sleeping 4 hours a night, individuals' performance on a reaction time test is pretty similar to someone who's been up more than 24 hours. And performance continues to degrade over a couple of weeks of nocturnal sleep restriction. So even curtailing to 6 hours time in bed, performance continuously gets worse. And at the 2-week mark, performance on someone who's been chronically sleep deprived is similar to someone who's been awake for 48 hours. However, this disconnects from your subjective experience of your own sleepiness. So you can see here on the right over the same time scale, After a few days of chronic sleep deficiency, you no longer perceive that you're getting sleepier every day. This just becomes your new normal. But objectively, your performance continues to degrade. Melissa St. Hilaire at the Brigham did a similar study in looking just at the 4-hour group of that prior study, essentially. So a new experiment, but same design, where they came in at baseline well-rested. They had 2 days in the lab where they were restricted to 4 hours time in bed, and then they got a 10-hour sleep opportunity. And they came back to the lab for 2 more nights, 4 hours each time, another 10-hour sleep opportunity. And what you can see here is even interspersing a 10-hour recovery interval every third day, objective performance continues to degrade over the week that this experiment is going on. So a recovery day every third day is even insufficient to restore baseline performance when you're only sleeping 4 hours a night. Circadian misalignment, sleep at an adverse circadian phase is shorter and more fragmented. So shift workers have to think about that when they're trying to sleep during the day. There's things you can do to help with that, to optimize your environment. But if you're misaligned, that sleep that you get during the day is going to be shorter and more fragmented than it otherwise would be. And this has a variety of adverse health consequences in and of itself. These things interact with one another. So if you're chronically sleep deficient and you're working at an adverse circadian phase, your performance is at its worst at that adverse circadian phase. So you can see in this study over a 3-week interval, this performance continues to get worse across the 3 weeks with 5.5 hours of sleep at night, and it is by far the worst at an adverse circadian phase. So for these people, after being awake a long time and then habitually a couple hours before your habitual wake time is your worst period of neurologic performance. So those are how those concepts fit together, and we'll apply them to a fatigue risk management program in a little bit. I want to touch on sleep inertia. I mentioned this is that feeling of grogginess that you feel immediately upon awakening. This was discovered by the Israeli Air Force, where they were having pilots stay in their planes and then do a sudden emergency launch, and they had a number of accidents. It's been studied extensively in the lab, and you can detect this impairment after awakening in the lab for a very long period of time. It seems to dissipate at sort of a logarithmic scale. We're learning more about how fast this dissipates in the real world. It doesn't seem to be quite as long, but in the lab, you can detect it for quite a long time. And then one of the local investigators shared this slide where they did an fMRI on people following a 45-minute nap at 4 a.m. So really a circadian nadir, a 45-minute nap at that time, and their frontal cortex and thalamus specifically were pretty slow to recover for up to 30 minutes after awakening. So I shared with some of you in the earlier discussions we were having that I used to work as a paramedic, and that's where my interest in sleep and shift work came from. I still work in that with collaborators from my dissertation. One of them is Daniel Patterson. We were interested in this phenomenon because we need to give guidance to EMS professionals and people who work in the fire service who are working 24 or 48-hour shifts at a time. So they really do need to sleep. It's where do you place that sleep? How do you optimize the environment for that sleep? And they often have questions like, well, if I sleep too long, I feel worse. Maybe I shouldn't sleep at all. I feel better if I don't sleep at all. So we did a study with a simulated 12-hour night shift where we randomly assigned individuals. They came in a couple times, but they were assigned to no nap, 30-minute nap, or 2-hour nap that would occur at 2 a.m. And what we found in the PVT testing is that we do detect sleep inertia after these naps. As you can see here, where their number of lapses are higher than they were pre-nap. But those people at the end of the shift did do better than those who didn't sleep at all. And this is also true in a less substantial way for reaction time in milliseconds. So we didn't find any difference in performance between the 30-minute nap, the 2-hour nap. There was some sleep inertia in both. In this case, it dissipated really quickly in less than 10 minutes, and either is better than not napping. So that's generally the guidance that we're giving now. And I'd love to do more sleep inertia studies in real-world environments with sirens and temperature changes and things like that. I think that'd be really cool. There are also age-related differences in performance. It seems as though the adverse effect of sleep deprivation on reaction time is greater among young adults, and that our tolerance to acute sleep loss improves with age. It's not entirely consistent, but that seems to be the case. And that's also supported by public health data showing the age distribution of crashes in which there's no intoxication being the highest among individuals who are age 16 to 27. Peak age of crashes being at 20. And one thing to keep in mind about this, and we also discussed this earlier, is that often like physicians in training, they're the least senior, they fall in this age range often. We're asking sort of our most vulnerable employees to work the types of shifts for which the risk is the greatest for them, rather than the ones who may be able to handle it a little bit better. Sleep deficiency also impacts your mood, not only your safety. This was a study from a couple of years ago that I really, really like, how they sleep restricted individuals to 4 hours time in bed over the course of 5 days. And then they have this sort of really terrible randomization where from there, after 4 hours time in bed for 5 days, you get randomized to either get no sleep, 2 hours sleep, 4 hours, 6 hours, 8 hours, 12 hours, 10 hours. And they assess their mood using the POMS total mood disturbance scale. And what you can see is a clear dose response relationship where if you've been sleeping 4 hours per night, yet as I should have mentioned, your mood gets worse throughout the 5 days continuously as you're restricted to 4 hours. And then if you're randomized to get no sleep, it goes much, much worse. 2 hours, 4 hours, you continue on this sort of linear fashion you've been on. But even if you're randomized to 10 or 12 hours of sleep in this experiment, you're still not quite getting back to where you were at baseline, calling back to the need for multiple days of recovery after these sorts of bouts of chronic sleep deficiency or acute sleep deficiency. So we know that there's a close relationship between sleep deficiency and mood, and we also know that work hours at their extremes certainly decrease the opportunity for sleep, and people sleep less when they're working a lot. There's been a series of papers looking at depression from the beginning of medical residency to the end of their first year. And in each one of these cases, in each one of these studies shown here, the baseline prevalence of depression upon entering residency was less than 5%. And in every case, the prevalence of depression by the end of that first year has at least doubled, and it's sometimes gone up to 8 times higher throughout that first year in residency. There's a nearly linear relationship between the number of weekly work hours in this population and their prevalence of depression, or the change in their PHQ score at least. And this is not unique, and it's been reported in a series of studies as well. And we were aware of this, and burnout is a common talking point in the medical profession in general. It's especially at top of mind at our hospital system. And they actually did an internal review, and they found that, well, they were probably expecting sort of the EHR experience to be the most common driver of burnouts, as it's talked about a lot, or something else. But sleep-related impairment was actually found by self-report at faculty at our hospital to be the most common driver that they perceive towards their own burnout. And based on this finding, we were able to get funding to do a study. This is preliminary data that we had at the time. We're working with an insurance company where we were able to enroll people and screen those at risk for sleep disorders and route them to get treatment for their sleep disorder if they were at high risk for one. And we found that a program like this, just addressing the sleep disturbance specifically, reduced psychological distress in that population over a 6-month follow-up interval. So putting this together into our Be Well MD program, we did a baseline intervention, which was a sleep health education and sleep disorder screening session. And then we had a 6-month follow-up assessment. We were able to recruit over 1,000 faculty in and around the Mass General system. And after going through the sleep health education, they picked up an iPad that was under their seat. So we stocked the lecture halls with iPads, and they were able to immediately do a survey with validated screeners for common sleep disorders and also for burnout. And if they screened positive for a sleep disorder, they had the opportunity within that interface to immediately grab an appointment at the sleep clinic. So we'd set some slots aside so people, if they screened at risk, could get in pretty rapidly. And what we found was that nearly a third screened positive for at least one sleep disorder, either sleep apnea, insomnia, shift work disorder, or restless leg syndrome. And 90% of those who screened positive were undiagnosed and untreated and no history of these sleep disorders. And in addition, if they screened positive for a sleep disorder, they were nearly 4 times as likely to screen positive for burnout. So sleep disorders, sleep deficiency, inherently tied to burnouts. Probably more well-known is the association between sleep deficiency and medical errors. This paper has been around for more than 50 years. It's looking at physicians who are reading ECGs after a night shift or not, and finding that there were many more errors made among those who were sleep deprived in interpreting the ECGs. Then nothing really happened for quite a while. In the late 80s, there was a very highly publicized and tragic patient safety event that occurred in New York State that's promoted awareness of this relationship between sleep deficiency and patient safety, and it led to changes. So in 2002, the ACGME instituted a rule that you could work up to 30 hours consecutively, and you could average 80 hours per week of weekly work hours, and you could flex up to 88 if you wanted. And that started a series of papers from the group that I ultimately joined, showing that when you work 24 or more hours, you had a higher risk of crashing your car on the way home. You committed more needle stick injuries in the hospital. You committed more serious medical errors in the ICU, more medical errors overall, adverse events and intentional failures, and you had less sleep. So in response to that, what was then the Institute of Medicine, now the National Academy of Medicine, convened a group to develop recommendations for what resident duty hours should be. And they came together, reviewed the literature, and came up with the following recommendations. Explicitly that working more than 16 hours endangers patient safety and health of residents. That work hours should be limited to 16 hours or less. And then there were some other things about protecting time for sleep of at least 5 hours and providing transportation for residents who are fatigued and need to have certain amounts of time off after particular types of shifts. And they acknowledged that it would cost about $10 billion to support this, because you need to bring in more residents so that you can all work shorter shifts on average. And the ACGME took this into account, and in 2012, they instituted new rules, and I've crossed out what they didn't adopt here and kept what they did adopt. This changed in 2011. They did limit PGY1s to work no more than 16 consecutive hours, and they needed 8 hours off after a day shift, couldn't work more than 20 consecutive 16-hour shifts. They didn't do anything about transportation, and they limited this to PGY1s only because that's where the bulk of the preliminary evidence had come from, these first-year medical residents. So then we studied the impact of this policy change by taking the cohort from 2002 to 2007 that was the source of all those papers I had scattered on the slide, and enrolling a new cohort of medical residents who were entering residency from 2014 to 2017. And we invited everyone who matched to a United States residency program to participate. You can see our participation rates here at the top. And we ended up getting about 15,000 PGY1s to enroll and contribute 80,000 months of data. They completed surveys each month about their sleep, their work schedules, medical errors, adverse events, things of that nature. We did a pooled analysis here comparing results from these two cohorts to look at the effect of the policy change. And you can see here that weekly work hours went down from 71 to 62 hours, but the hours engaged in patient care actually remain almost exactly the same. So they're spending the same amount of time dealing with patients and learning in their hospital setting. Extended duration shifts went down. They weren't eliminated completely. They're not allowed to work these during this time, but sometimes they still snuck through. So they went from 4 a month to less than 1 per month. Nightly sleep duration went up by more than 20 minutes. But sleep duration when they were working an extended duration shift went down from 2.5 hours to less than 2 hours in a 24-hour interval. So what effect did that have on safety outcomes? We found that the incidence of every single outcome we looked at was significantly reduced after this 2011 limit went into place. So there's a 32% lower risk of a medical error, 34% decrease in preventable adverse events or errors that resulted in harm to the patient, and more than a 60% reduction in errors resulting in patient death. We looked at weekly work hours specifically because we thought that the 80-hour limit actually remained unchanged between the two policy intervals. So is there a relationship we can investigate to advocate for perhaps a lower weekly work hour limit? And you can see here that even controlling for hours in patient care, as you work more weekly work hours, there is a dose-response relationship with increasing likelihood of medical errors and preventable adverse events, as well as attentional failures and fatal errors. Then we followed that up with a separate analyses among the more senior residents. So what I was showing you before were residents in their first year of training. These are residents in PGY2 or above, and we found nearly the same results in this population as well. And we then conducted a meta-analysis. So our studies are observational. There have been relatively few randomized controlled trials in this area. So we did a meta-analysis looking at pooling all the observational studies together and looked at mortality before and after these reforms and found no difference in mortality before and after the 2011 rules were introduced. And then looking separately at randomized controlled trials that have been conducted in this area, there's no evidence that shorter shifts are harmful in any way. So in fact, they may be beneficial. Despite that, there's a large push towards getting back extended duration shifts for everyone. There were two very influential non-inferiority trials, one in internal medicine called iCompare and one in surgery called the first trial. And they were able to get funding to randomize programs to a flexible schedule or a standard schedule. And you can see what flexible entails here. It means you're working up to 28 hours. You don't need 8 to 10 hours off between shifts. You don't need 14 hours off beyond house duty. And they carried out these studies nationwide. And just to note here, this is a non-inferiority design in both trials. So these seek to determine if the experimental condition is not worse than the control by an acceptably small amount. It's subjective. You set that amount, what you're willing to accept. And they set an absolute difference of 1% in 30-day mortality at the hospital level, which would be about 39,000 additional deaths per year. And also a large absolute difference of 1.25% in 30-day mortality or serious complications at the hospital level for the first trial. And they did find that it was non-inferior with respect to death or serious complications. However, participants in the study got about 20 minutes less sleep per night if they were in the flexible group, which, if you recall, was the same benefit we observed when we studied the first policy change. So getting rid of extended shifts or putting them back in seems to result in about 20 minutes of sleep per night. And they did not establish non-inferiority of neurobehavioral performance. So people were doing worse on the PBT beyond the preset non-inferiority threshold. They also had worse well-being. They were more likely to report a negative effect on their time for family or friends, their hobbies, their health, and their time for rest. But despite that, the current rules that are in place now as of 2017 again permits shifts of 24 hours plus 4 hours for continuity of care. So 28 hours, 88 hours a week in the US. And it's pretty similar in British Columbia. They're allowed to work 24 to 26 consecutive hours, and one in 4 report working more than 80 hours per week right now. I'd just like to highlight that other countries have been able to train physicians without introducing these types of schedules. You don't inherently think that you have a less good physician if they came from England or if they came from France. So other people have figured this out, and I think we could challenge ourselves to do a little bit better in this area. So despite the policy change most recently in 2017 that again allows people to work extended duration shifts in this setting, there does seem to have been a cultural change. So we did a follow-up study looking at a new cohort of participants from 2020 to 2023, just to kind of see what's happening now in the current environment, to see if people reinstituted them after they were banned or if they have found another way to provide these schedules. And it doesn't seem like they're working them very often anymore. So in cohort 3, they're working about 1 extended duration shift per month over a year in surgical programs, and that's going to be the highest frequency of extended duration shifts. And they're clustered a lot more, so they're working about 1 per week in months where they're worked, and they'll go a lot of months without working any. So there does seem to be a cultural change that's taken place that's led to a more healthy and sustainable work hour structure. But one thing to point out is that the proportion of extended duration shifts without any sleep has gone up in every cohort we've looked at. So if you're working extended shift, and I told you that on average we're getting 1.8 hours in the last cohort on one of those shifts, the number of those shifts you work, 35% of them now, they're getting no sleep at all. And that's a pretty radical change from where 9 out of 10 of them, they would get some sleep in the early 2000s. So the pace of work and the demands of work when they're there have certainly increased. The prevalence of extended duration shifts looking at other levels of training, so PGY2 plus have become less common as well. So if you're a more senior resident physician, you're going to work still less than 2 per month. If you're on a surgical rotation, you'll work about 4 per month now. Months without any extended shifts have gone from 20% to about 75% in their first year for PGY1s, and 25% to 64% among PGY2+. So we think this is a trend in the right direction for sure. And if you ask residents, this is a study across Canada, including respondents from British Columbia, the residents themselves report that their quality of care was no longer consistent after working for 16 consecutive hours on average. Some of them, 20% of them, said no longer after 12. And there's also public unanimity on this issue. So we had done a public health surveillance project during COVID where we were asking people their opinions about lots of different things like vaccinations and things of that nature. And we added on how they felt about resident physician work hours. So this is a nationally representative survey that aligns with 2020 US Census estimates of the United States population in terms of race, sex, ethnicity. And you can see a bunch of demographics here on the left. And what the number represents is the proportion of people that said resident physicians should work something less than 24 hours. So we asked them what's the maximum number they should work at a given time. And the majority responded 12 hours or less and no more than 60 hours per week. But it's striking to me that in current times, we don't agree on a whole lot. But if you look across all these different categories, including political orientation, no one thinks that resident physicians should be working 24 more hours at a time and taking care of patients. So I think one of the main things this comes down to is just what outcomes do you value? There are clear evidence that work hours are detrimental to resident safety and well-being. They harm patient safety. They're associated with less sleep, reduced neurobehavioral performance, higher rates of errors. There's no evidence that eliminating them negatively impacts the training, and hospital-level outcomes are similar in these different paradigms where they were and were not restricted. So if they're similar, why are we exposing our colleagues to harm? We recommend limiting shift length to 12 to 16 hours, minimize consecutive nights on duty, so no more than 4 in a row, provide adequate time off for recovery after a string of nights. Like I said, even this one bout of 10 hours is not enough to set you back to baseline, so make sure you allow enough time off between shifts and adequate time for recovery after a string of nights. When shifts are shortened, you do need to think about things like a structured handoff program. So as you have more clinicians trading off patients in 8-hour increments, information can be lost in those handoffs, and there are structured programs to help make sure that does not happen. And also think about anticipating or deferring non-critical night work. The UK hospital night program is a great model. Patients that are stable, they're monitored from afar at night. I think Dominic's work is great. Applications to this area, not unnecessarily waking up patients can also be good for the doctors, and it may aid patient recovery as well. Programs also need to provide support for transportation. Like I mentioned, your impairments, your risk of getting a crash on the way home, the liability for yourself in the hospital system if you've been up for 24 hours and driving, they have to provide an option to get people home other than them driving themselves. And they should provide space to sleep at a hospital that's ideally, private, dark. You have the ability to control the temperature, minimize sound. And finally, consider screening for common sleep disorders. As we found in our own hospital system, I mentioned a 32% prevalence of undiagnosed sleep disorders. We've also done a number of different studies in public safety. So this is 3 different studies looking at fire, police, and fire-based EMS. And every time we do one of these sleep disorder screening projects, we get essentially the same answer. Like about 30% of people will screen positive for at least one sleep disorder. And the demographics of what that sleep disorder is change from project to project. When we've done nurses, there's more insomnia and less OSA, but it's still about 30% every time. And the vast majority are undiagnosed and untreated. This does matter. Individuals in these studies that screened positive for a sleep disorder had a higher odds of a motor vehicle crash, a near crash, falling asleep while driving, occupational injuries across fire and EMS, and police officers reported making more errors over the course of their job as well. It's also associated with health. So screening positive for a sleep disorder is associated with increased odds of cardiovascular disease, diabetes, depression, anxiety. And this is not the only study to show that. This is prevalent throughout the literature. It's also associated with mental health. So those who screened positive for a sleep disorder had more than 4 times the odds of occupational burnout in the public safety setting, which is pretty close to what we found in the hospital setting as well. A little less than 4 for us in the hospital. And these considerations in public safety are a little bit different. These groups, like I mentioned, they're working 24, 48-hour shifts. They need to sleep there. So you need to think about how you can promote a healthy sleep environment at these stations, which are, sometimes modern, sometimes fairly old, but they certainly weren't designed with sleeping in mind. They were designed for something else. So sometimes you can retrofit them. This is a picture of one of our collaborators installing blackout shades in Seattle at one of the firehouses there, focusing on keeping the light out of the sleeping areas. Think about providing personal space and beds and temperature, same as in the hospital. The other thing in this setting that is way too common is when a call comes out, it alerts everyone associated with the agency, and only a couple of people tend to need to go. And now the more modern systems are moving towards personalized alarms so that there's not an air raid siren going off when just one crew needs to leave. But there are things like that I think as sleep and circadian scientists we can we can weigh in on and provide a fresh pair of eyes. And they also need to have rest policies. This is mostly about culture. Often we see it more often in fire departments, particularly if they're county-based. If leadership is around, there's a large hesitancy on the part of employees to sleep. But as I mentioned, with the duration of their shifts and the unpredictability of their calls, they really need to be invited and encouraged to sleep when they have an opportunity to do so. So thinking about what a modern fatigue risk management program looks like in public safety, this is work done by a collaborator of mine, Mike Binney. He's in West Metro Fire Rescue in Lakewood, Colorado. He did this fantastic study for his MPH thesis that I just thought was awesome. And got everyone at the fire department, it's 200 individuals, to wear a whoop strap. He had them do occasional surveys on Qualtrics, and then he linked all this data into their 911 call system and their staffing data. And most of these agencies have a sophisticated system status management system where they always know where each unit is, and then they shuffle them around to provide coverage where they think a call is going to come, right? So if one crew gets called out, another agency from a slower region will tend to move over into the other agency. And they had that available. And he's been able to add in data from the WHOOP to that whole system. So he knows at any given time, how much sleep his various units have had recently, and can make some more considered decisions about how to utilize this personnel. And ultimately, it looks like this, where you could see where all of your units are. You could see how busy they've been. You could see how rested they are. And then you might consider moving some of these guys here in District 3 over to District 1 and swapping them back and forth so that you can have your most well-rested personnel available in the area where you predict that you will need them. And I think this is where the field is going to. I think it's a great example of that. Just to briefly touch on a couple of other industries. We talked about this, I guess, in our lunch with the trainees. We've done some work with bar pilots who go out and they meet ships that are coming into a local harbor. They board that ship, they captain the ship into the harbor and put it, whether it's at the dock or whatever they're going to do. These industries have been around for a very long time, and sometimes historical traditions just get embedded and you don't think twice about why you do them and if they're working for you or not. So they work for 2 weeks on, 2 weeks off, just throughout the year. And after you get a call, it generally takes 12 to 14 hours to do a call. It can take a long time to respond to that call out on the boat. And then they're off for 24 hours. So when you only have 2 watches as they do, everyone switches off on Tuesday. You could see that on Wednesday, you start needing to call people in from home who should be off on their 2 weeks off. On Thursday, even more. On Friday, even more. And then it waxes and wanes in a completely predictable schedule because they only have 2 watches. So think about how much you're cutting in to these people's time to recover on their 2 weeks off. Are you supporting them in that? And also what we suggested to them was more of an 8-watch schedule where they had new people coming on every 3 days so that this pattern could perhaps be improved. The other thing that is often the case in different settings is hyperfocus on acute sleep deprivation and less of a focus on chronic sleep deficiency. So aviation is a model for a safety-sensitive setting that's really sophisticated in the way they think about fatigue risk management, but they also can sometimes overly focus on a narrow window of time. So when they're using programs to predict how bad a schedule is, usually they're looking at the past 5 days, past 7 days or so. And we looked at data from an aviation company and found that looking at duty hours over the past month, there's a nearly linear relationship with the likelihood of a fatigue report where the pilot calls off and they have to get another pilot to come in and fly that plane with the amount of duty that they've worked in the past month. I think it's really neat that you can detect it over an entire 30-day interval. And this also shows up in the objective data they collect from the planes as well. This right graph is just modeled against the mean. So most people are doing about 80 hours in a month, and those on the upper end. You can tell from what they worked over the past 30 days, their odds of a fatigue report are increased. So I think for all these different reasons, good sleep health is critical for performance, health, and well-being. Shift work does make it difficult to get adequate sleep. It's unavoidable, but I do think that we can do better. Work hour limitations had pervasive substantial benefits. Reductions in work hours or flexibility in the design of those hours is feasible. And I would just reiterate, we need to provide support and protection for those who are asked to work extended duration shifts. And with that, I'd like to pivot to a couple of ongoing projects that I'm really excited about. So we got another 15 minutes or so to do this. The first is a passive OSA screening project. I showed a number of slides about screening for sleep disorders and the association with burnout, safety, and adverse outcomes. Trying to think about making that a little bit easier to identify sleep disorders. They seem to be incredibly common, often underdiagnosed, and it's not something that you commonly have a conversation about with your doctor. But it's also true that what the components of an OSA screening questionnaire are almost entirely available in the medical record already. You know, they're looking at demographic characteristics, comorbidities, things like that. And then they add a question about snoring often, and they add a question about how sleepy you feel. So most of this can be gathered from the EHR. And we are currently testing whether implementing a tool that identifies the risk of OSA using these components is helpful in a few different ways. So this is a design of our study. We have 10 primary care clinics that are participating. They have what we call a SLIM risk assessment incorporated in their EHR, which I'll show in a couple slides. So when a patient comes in for a visit, if they are not deemed as a high-risk OSA patient, nothing will happen that's any different from normal. There's no alert to tell them they're not at risk. Nothing happens. But if they're positive, there'll be a yellow banner on the left side of their screen as a health alert that says at risk for OSA. And if they click into that, then there's an order set available to make things really easy for them to refer the patient to sleep medicine, refer to the study team to potentially take a home sleep test from us, or suggest some other treatment pathways. If they select the HST, the patient completes it, we send the results back to the PCP, and the PCP decides what to do. So this is the first version of the SLIM. It was developed at Mass General by another group there. You can see that they, using age, BMI, diabetes, hypertension, smoking, and sex, assign varying points to each of these characteristics to try to predict the risk of OSA. That seemed in their initial publications to perform similarly to the stop bang, so at about 80% specificity and a little bit lower sensitivity, but it performed pretty well. And other people have taken off with this and varied it. There's a size 5 SLIM model that only looks at sex, age, BMI, and hypertension. And at Banner Health in Arizona, they've implemented a much more longer list of comorbidities. So they've added in stroke, for example, impaired cognition, sleepiness. And they've taken great strides to make sure that their scoring criteria is such that if the patient screens positive on their exam, they almost certainly have OSA. So their likelihood ratio for a positive test is 11.3 in their sample. And they're doing that because really don't want to send anyone unnecessarily to the sleep clinic, only the absolute highest risk patients. We are doing this at Sutter Health through a collaboration there. And it's something that we wanted to be attentive that this has only been implemented a couple places. The demographics of patients at Sutter Health are not exactly like those in Boston or those in Tucson. And we also had some ideas about other comorbidities that we wanted to add. So we made our own version of SLIM, looking at patients in Sutter Health population that had incident OSA diagnoses in the past couple of years. And we really wanted to land somewhere between the initial SLIM tool, which was pretty sensitive, less specific, and the Banner Health SLIM, which is very, very specific, but misses a little bit on sensitivity for a different purpose. And we have come up with this strategy with varying points assigned to varying BMI, age, prediabetes, type 1 diabetes, type 2 diabetes, hypertension, smoking, coronary artery disease, et cetera. We added congestive heart failure, depression, anxiety as well. If they get over 48 points, then the alert is triggered. And we feel pretty good about this in applying it to a primary care population at the start, at least. So we derived that in a population from a sleep clinic that had incident OSA. And then we applied our tool to the Sutter Health system at the clinics where we will be doing the study, which is in primary care. And this is an example of their patient population here. The current prevalence of OSA at Sutter Health is 9.2%, which is quite lower, or it's lower than national estimates. And when this tool is turned on, assuming the case mix stays pretty much the same, this is going to alert for 1 in every 6 patients, which is kind of a lot. But then we're ending up with a prevalence that's closer to what we think the national prevalence of OSA is. This is what it looks like and what we're asking the providers to do, just acknowledge the alert and use their own clinical judgment. From there, we're not directing care. It's a quality improvement project just to increase identification of OSA. But they'll be able to click into the alert, and then if they want to directly order a home sleep test, we will provide one to them. And then we get it back to them in their Epic inbox like this. And we send them a message saying, hey, the results are back. And we're using the Night Owl HST, which is one of the more common HSTs. And you're able to make sure you make decisions based on that, along with watch pattern apnea link. We like the Night Owl because it's entirely disposable. It's very tiny. It's easy to use. And it's good for 7 days. We're asking patients to wear it for 2 days to account for night-to-night variability and make sure we have complete data. So the outcomes for our study are the rate of screening before and after this was put into place. And I know sounds a little weird because everybody's getting screened, but the rate of screening in the 2 years leading up to us turning this on is quite low. And once we turn it on, the physicians will have to acknowledge the alert for us to consider that patient to have been screened. We're also interested in the proportion of patients that screen positive that ultimately get a diagnosis. So how well does the tool predict OSA risk? And we want to look at agreement between just that EHR-based tool and the HST result among people that get an HST as part of the study. We're really interested in process of care measures. So how long does it take people to get into the sleep clinic? How long does it take them to get treated, et cetera, before and after the intervention, and among the SLIM and HST groups? And the screener just went live last week. So just started collecting data. Lots of people screening. And the second project I'd like to talk about is, sorry, I can't see my header here. Nobody can see the header. No, well, it says solar jet lag at the top. What's up? Go. Yeah. Oh, that's what I was. Oh, thank you. Thank you. Okay. So we and others have shown that where you live in a time zone has an impact on your health. One of the first studies to show this, it was in about 2015, 2016. There's a paper from the National Cancer Institute investigators, and they showed, looking across a broad range of cancers, increasing distance westward within a time zone was associated with increased incidence of certain cancers. We were interested in that paper, and this is my wife, Trangbo Pham, and I and her postdoc student developed this model. She is a geospatial scientist who's interested in liver cancer. I'm a sleep and circadian person who knows that the liver has a really strong circadian control. So maybe we'd see something in liver cancer specifically. So we looked to develop our own model that's not just positioned in a time zone, but also accounts for directly sunrise time and sunset time where you are. And to give you just a spoken word example, if you're living, say, in Indianapolis, Indiana, your sunrise is, say, an hour and 15 minutes later than someone who's living in Rockport, Maine for part of the year. And your sunset is also later. So we have these, meaningful differences in the timing of our photo period, depending on where we live. And we think that this impacts health through chronic circadian misalignment. So this is an illustration of our model. We have spatial resolution of 30 meters squared. We incorporate a variety of things in the model. We can link it to, whatever you would like. This is in a very broad scale, kind of what a map looks like in terms of our light exposure. And since that first paper where we looked at liver cancer, we've shown that this does track with sleep timing. So individuals in the West that we have studied at least do tend to sleep later and get up later than individuals in the East. We've shown linkages with obesity and diabetes and non-alcoholic fatty liver disease as well, which are all contributing factors to liver cancer. And a postdoc in my wife's lab has also shown that solar jet lag, interacts with polycyclic aromatic hydrocarbon exposure to influence the risk of other types of cancer. So we have a couple of grants to take the solar jet lag model and apply it in different populations. Two of them are population-based, and one of them is specifically among the VA healthcare patients. And if anyone's interested in using it, we have it available for linkage with other cohorts and existing data. If you have location, you can use this as an exposure model if you wish. And I'd like to thank the many, many people who contributed to this, and happy to take any questions that you may have.
Thank you.
Thanks.
That was great. And I think so much of our work is focused on brain signaling or the mouse brain. And it's so nice to take a step back and think about the real world consequences of sleep and sleep deprivation and sleep fragmentation and all of that. So thank you.
Thank you.
This was different than how we normally talk about sleep in our lab. So it's really nice.